Okay, I want to thank everybody for coming today. My name is Jenna Marquard. I am on the leadership team for the Massachusetts AI and Technology Center. And today's webinar, we're going to be talking about cognitive assessment methods for AD and ADRD research projects. The way that we're going to structure things today is that Catherine Papp is going to give an overview of why this is an important area. And then we've got three presenters who are going to talk about personal experiences using different cognitive assessment methods and lessons that they've learned. And then at the end of those presentations, we'll have time to ask and have questions answered. So I want to briefly introduce our four panelists. So Dr. Papp specializes in memory disorders and focuses on early detection of Alzheimer's disease. Her work includes sensitivity memory tests, digital technologies, and exploring lifestyle changes that may reduce cognitive decline. Within the Mass AITC, she mentors teams on cognitive assessment tools. Dr. Busa is focused on human movement, including gait, posture, and physical activity, to using complex systems to identify early signs of aging and disease. He also collaborates on Mass AITC pilots to study subtle movement changes as potential digital biomarkers for AD and ADRD, often using wearable technology. Dr. Vahaya specializes in geriatric psychiatry, focusing on technology and informatics approaches to assess and manage older adults. He leads programs on aging, behavior, and technology. And Dr. Singh modernizes neuropsychology through digital tools, and she's both a licensed clinical neuropsychologist and holds leadership roles in research and teaching. So Kate, I'm going to stop sharing my screen and hand it over to you.
All right, thank you so much, Jenna. Like Jenna said, I'm a neuropsychologist. I'm very interested in digital cognitive assessments to advance early detection and tracking in preclinical Alzheimer's disease. But I'm also involved in a number of secondary prevention trials and in the design and development of the protocols for those studies, including the A4 study, the HEAD study, and the US Pointer study. And I've learned a lot about the importance of good cognitive screening in that context, and then also learned about that more in the context of being a mentor for Mass AI CT and seeing, some of the challenges on the ground and in the community in terms of cognitive screening. So many of us are interested in Alzheimer's disease, neurodegenerative disorders, and the goal of cognitive screening in this context is to identify appropriate study participants. And usually it means identifying people who are cognitively unimpaired, so people with normal cognitive functioning, people with mild cognitive impairment, so abnormal cognition in one or more domains with largely intact everyday functioning. And then individuals with dementia. So these individuals have a combination of abnormal cognition and impaired everyday functioning that is a decline from a previous baseline. And unfortunately, there's a lot of barriers to identifying individuals with these disorders because oftentimes people who have mild cognitive impairment either aren't aware that they have it. There's a level of anosognosia or lack of awareness, so they might have been told they have this diagnosis, but they're less able to share that. And then also that sometimes people don't get formal diagnoses and there's still stigma around a diagnosis of Alzheimer's disease. So they might think they have something like hardening of the arteries. Likewise, we know that there's a lot of people out in the community who are, functioning in everyday life, but may sort of have an underlying neurodegenerative disease that's in the early stages and might not yet have a diagnosis of something like MCI or dementia, despite showing changes in their cognition. We know that there's consequences for our research studies with poor cognitive screening. The challenges are that we could fail to enroll individuals who have the condition of interest. So we're recruiting for MCI, but we're mostly enrolling normal folks. We can also enroll individuals who don't have the condition of interest. And this obviously leads to wasted time, resources, and then decreased study power. So what's the process usually that's used for cognitive screening? This is partially dependent on the referral source. So for example, if you're referring from a clinic, you might already have information about a participant's diagnosis because they're at in a clinic setting. So they might already have a diagnosis of MCI or dementia that's on record. But it's different if it's in the community where you don't have a lot of outside information about an individual's current cognitive functioning. Generally, it involves an initial telephone screening and then in-person screening, potentially in an ideal situation with a study partner or an informant if you're recruiting individuals who have MCI or dementia. However, there's no current gold standard for cognitive screening. These are two examples that are commonly used, the mini mental status exam or the MoCA. These have been around, the MMSE, since the mid-70s. But despite this, these are well used instruments, but there isn't one current gold standard. And this is for good reason. There's a lot of challenges that we face in cognitive screening. Many factors that are unrelated to neurodegenerative disease impact performance on a cognitive test. And in particular, as neuropsychologists, myself and colleagues are very aware of the impact of different demographic factors. So I'm just going to give you an example here of the impact of age and education on how somebody performs on a cognitive test and how that has knock-on implications in our interpretation. So this is an example of the digit symbol substitution test. It's frequently used in the clinic and in research studies. Participants are asked to fill in the symbols that go with the numbers as quickly as possible. It's a measure of attention and processing speed, and the total score is the number of items that are completed within a given amount of time. Now, in this example here, we have a raw score of 38. And if we look at that performance in a 35-year-old, that would be considered to be at the second percentile or in the borderline impaired range. In contrast, if an 85-year-old scores 38, that's average and they're in the 72nd percentile. So this highlights that raw score performance by itself has to be contextualized in terms of a demographic factor like age. Likewise, here's an example of a raw score of 35 in a 65-year-old. But if you have 12 years of education, that's an average score, so 55th percentile. Whereas if you have more than 16 years of education, that's in the low average range. So again, highlighting how the raw score in itself needs to be interpreted in the context of demographic factors. We also know that there's other things that can impact cognitive performance, sensory issues, particularly in older adults and in telephone screens. Poor hearing can lead to lower scores. Poor vision and in-person testing can also have an impact, but sometimes to a lesser extent than poor hearing. We know that there's acculturation and linguistic factors in cognitive testing. So not only in the content or the stimuli, so for example, with the MoCA, knowing what a rhino is or a camel is, but also familiarity with the testing scenario. So, having been in a school setting or in an, the US school system and knowing, the expectations around a tester and a testee and speed and accuracy and those things that some groups are less familiar with. Other factors could be an individual's mood, level of arousal. I'll give you a little example of this. The Yerkes-Dodson law of arousal and performance is something that we commonly use in psychology, and we know that there's an optimal level of cognitive performance that occurs where people are sort of at a mid-arousal level. So if you're not aroused, you're tired, you're bored, your performance is low, and then if you're extremely high anxiety, you had way too much coffee, or you're very anxious about your own performance, then your performance also dips down. So we don't perform at the same level all the time. There's impacts of things like level of arousal that can influence how an individual performs on a given day or at a given time. So, needless to say, there's a lot of context that's important in interpreting somebody's performance on a cognitive screening measure. And furthermore, if we look at cognitive screening measures just in isolation, we can't know whether there's been a change in someone's cognition that is recent, persistent, and worrisome that's consistent with an MCI diagnosis or a dementia diagnosis. So we can use demographic corrections to get at some degree of understanding of, is this sort of a normal score for a person's hypothesized baseline, like their age and their education level, that can give us a bit of a proxy to say, okay, they should be doing in this range, but it's not a perfect solution. And in part, what's important is that cognitive screening should not occur in isolation, because when we're talking about a functional disorder, which is MCI and dementia, we have to account for whether there's been change in everyday functioning or whether the everyday functioning is preserved to really contextualize, again, how someone does on a cognitive screen. Um, so my recommendation would be, and this is what I've observed as being the most successful approach, is using a cognitive screening tool which has cutoffs and or corrections for different demographic groups. We've known over the past few years that a lot of our screening tools have inappropriately led to not including certain demographic groups, particularly underrepresented groups, into Alzheimer's disease research because they don't meet criteria based on cutoffs, but those cutoffs are not necessarily appropriate for those populations. So it's important to have appropriate cutoffs for impairment or non-impairment in the population that you're targeting. And then also combining a cognitive screening tool, whichever one you choose, with some sort of informant-reported functional questionnaire to make that categorization for research of cognitively unimpaired MCI or dementia. We know in certain situations an informant is not always available. There's debate in the field right now about whether self-report of functional change is reliable or should be used. I think at this point, there's arguments for potentially using self-report on functional measures, but an informant is an ideal situation where you get a report not just from the participant, but someone who knows them as well. And then I think another recommendation is to avoid administering multiple similar cognitive screening tools or the same screening tools repeatedly in the participant, because we know that there's significant practice effects when people do cognitive testing. So people reliably get better the second time around. So if you screen people with a measure and then classify them with a second measure in clinic, you might not be classifying them correctly because of the practice effect that they had based on their having recently done a similar type of cognitive test. These are my bias recommendations for particular measures. So this is something that combines some of the different measures that I've used in different clinical trials. The telephone interview for cognitive status is a good initial screener. I particularly like it because there are demographic cut points where you add points based on age, education, and membership in an underrepresented group. This is the cut points that we use in the U.S. pointer study, and I have found that they have been quite useful. I also think a clinical dementia rating scale, or CDR, is very useful for making a research diagnosis of normal MCI or dementia. It offers a staging system. It's pretty resource intensive, so there are other options that are available, like the Quick Dementia Rating Scale or the QDRS or the 88, that can similarly get at this staging idea in terms of function, but don't require the same amount of time or resources. But generally, the theme here is combining cognition with measures of function to screen people accurately as normal MCI or dementia. So I realize that the things that I have showed you are largely paper and pencil measures. They're oldies but goodies. They're from the past, but they're really what is the standard and what's been used. I think there's a lot of opportunities for digital assessments that have potential significant advantages. They could be more sensitive than traditional approaches. They're relatively inexpensive. They can be done remotely. They're non-invasive. They are self-administered, so you don't have a rater or an expert. You can also get repeated measurements, so you can more accurately assess somebody's cognition or function by getting more frequent assessments, thus more reliable measures. But I don't think that these, a lot of folks on this call are, and Dr. Singh might talk a little bit about this as well, are exploring these exciting different technologies and ideas to be able to better capture cognition and function outside of the clinic. But these devices I don't think are currently ready to be used in isolation to help with diagnosing, providing a research diagnosis for your study. There's certainly something that could be used as an initial screening, but I think these are at various stages of development, and there hasn't emerged a single sort of gold standard approach of how to use these digital tools. I will share with you right before I finish here one approach that we're taking in my group to develop sensitive and scalable methods for early detection and monitoring of cognitive decline within the preclinical Alzheimer's disease population that involves a digital approach. And so we've developed this web-based cognitive assessment with the idea that we can look at an individual's learning curve over time by having them do the same types of memory tests each day for a total of 7 days. And you can see here, individuals in red have elevated levels of amyloid, so they're have preclinical Alzheimer's disease, and individuals in blue do not have elevated levels of amyloid, so they don't have preclinical AD. All these participants are healthy, and what you'll notice is that they're performing similarly to each other on day 1 and day 2, but by the time we get to day 3, the learning curve has shifted. For those individuals with preclinical AD, their learning curve is much more shallow compared to those who are amyloid negative. So this is an early clinical or early cognitive indicator that these individuals who are otherwise appearing normal on standard cognitive tests are in fact showing subtle signs associated with preclinical Alzheimer's disease. And so what we're doing is taking this digital cognitive measure and we're pairing it now with blood-based biomarkers of p-tau217. And the idea here is that we can then combine these two scalable measures, a remote web-based assessment and an AD biomarker, and we can identify those individuals from a large population of individuals who are potentially in the preclinical stages of a neurodegenerative disease. We can identify those individuals who not only have biomarker signs of the disease, but have the earliest cognitive signs of the disease. And these individuals are particularly of interest for recruitment into secondary prevention studies, because these individuals are the most likely to be at imminent risk for cognitive decline. Additionally, down the line, these individuals are going to be the ones who are most suitable for potential early intervention should medications become available within this preclinical group. So this is one example of how what I think the future could look like in terms of cognitive screening. But for our studies where we're exploring these different types of measures, I think we still have to take the approach of using some of the more standard paper and pencil type measures to initially classify and identify appropriate research participants. So with that, I will stop sharing my screen and allow us to move on to our next speaker.
Great. Thank you so much, Kate. And I'm seeing good questions come up in the chat, and I encourage you to keep doing that. We're gonna speakers, as they finish their presentation, can take a look at the chat and respond as appropriate, and then we'll take time at the end to continue to answer questions. So Mike Busa is going to do our next discussion about some on the ground lessons learned from different cognitive screening methods that he's used.
Thanks, Jenna. Yeah, so my name is Mike Busta. I direct the Center for Human Health and Performance and co-direct the mHealth core facilities at UMass Amherst. And as you can see, have been involved with a number of studies. So these are the ones that I've been involved with that are associated with the Mass AITC over the last handful of years. And we've learned a lot as far as utilizing some of these tools. How can we sort of optimize the application of some of them, and what are some of the drawbacks and limitations, and where have we gotten to now? So a lot of this is actually with the help of Kate. So thank you, Kate, for your help over the last few years. So the study that I'm going to talk about kind of in more depth is this Meadow AD study, which was a year 1 AITC pilot. And originally the study was looking to recruit people with either diagnosed or undiagnosed MCI or Alzheimer's disease that fell into the mini MoCA range of 18 to 25, which is mildly cognitively impaired. As you can see from the table, the partnering company that we were working with really wanted to have a robust understanding of how different measures or different cognitive measures and different scores related to some of the more mobility markers that we were working on. And so we used like every measure under the sun at the initial screening. And so there was a lot to be learned from doing that. And so Jen, if you want to go to the next slide. So you can see that we applied all of these different measures. The tics in mini MoCA, or MoCA-T, as it's sometimes referred to, were done over the telephone. And a lot of them have overlap in either the specifics of the questions that they ask, or certainly a lot in the different areas of questioning that they ask. And so figured putting together a quick table for everybody to have a little bit of a cheat sheet here as sort of what are some of the dimensions that are inquired about with these different tests. And so you can see that there's a lot of overlap in these tests. And you know, as we have gone through some of these, we've seen different classifications for the same individuals across different tests. So if you want to go to the next slide, Jenna, this will be my last one. I wanted to show some results from the utilization of these tools. So the same tools that I talked about in the previous slide were what we applied in this particular test. And you can look at sort of how they related to classifying the individuals. And so the dashed lines that we have here are those are sort of the cutoffs that are typically used in many studies for identifying a functional impairment. And you can look at the distributions here. And so depending on which tool you used when, you get very different classifications for different individuals. And I think this speaks very much to the point that Kate was making, that any one of these things is very, very hard to use as a robust objective classifier. But you can see that as we go from left to right across here, this was actually the order that we applied these in. So people on a telephone screening call went through the tics, and then very quickly after that, they went through the mini MoCA. They were then either brought into the laboratory or not, depending on where we were in the particular study. And then they went through the MoCA, the mini mental, and the mini cog. And you can see that really depending on what we were using for a classifying instrument, we ended up having very, very different opinions of whether or not these people, what sort of bucket these people fell into, whether or not they were in the control group or in the group with cognitive impairment. And so I think this in one particular, in one particular case here, we can see that you have to color your interpretation very differently. And we also did an analysis of looking at some of the repeated questions that people got, maybe low score on the first time they did it, and then subsequent iterations because of the overlap in the content of these tests, and people did improve. And so that's no surprise there. But I think can serve as a fair warning that take the time at the beginning of your studies to really set these up and then move forward with them. The other thing I think that Kate's touched on is that some of these screening tools are really resource intense to go through. And so, the site that I work out of, we aren't a clinic. We are recruiting from the community. And we have lots of really nice community partners that have allowed us to be successful in bringing people in. But that being said, when we have an engagement with a particular community partner, or if we are running, say, advertisements in the newspaper or web ads or things like that, we can have major influx in the number of people that contact us. That we go through a multi-stage screening process, and just want to make sure that you're able to understand what the resources that are going to be required are to actually run people through this. So we are using the TixM quite a bit now, and so that has been a time effective resource for us. But we will have things where we run a web ad for a particular population, and we will get contacted by 150 people in a week, and we have to run them through screening. And of that 150, probably half of them get to the point where they actually need to talk to one of the study team members on the telephone. And so you can imagine how many person hours that results in for any particular enrollment, and that can take quite a bit of time, and in particular on smaller pilot studies that can be very challenging. And so I think having the resources to put into that, and really making sure you're able to account for that, and putting together best practices so you can kind of try to pull people out of the loop, and as many screening tools as you can put in place to allow folks to sort of self-select out would be a major suggestion that I have. And so with that, I think we'll head over to
No, thanks so much, Mike. One very sort of quick question was on the sort of order of magnitude on the number of participants that you've been recruiting in the studies.
Yeah, so a lot of the studies that have cognitive impairment or AD people, we're looking on these pilot studies, they're typically between 10 and 25 people per group. We have some other studies that are up to 50 to 60 people. And so, yeah, we're trying to enroll those numbers for these smaller studies. Yeah.
Oh, great. Ipsit.
Thank you. So I'm going to speak a little bit differently from how I usually do. I'm going to speak with my clinician and sort of clinical service administrator hat on. And the reason is, I think in a panel full of neuropsychology experts, I'm the geropsychiatrist. So I want to offer, I think, a perspective that complements what we've heard from Kate and what we will hear from Shefali, which is from the clinician perspective. I think a factor that I think we think about is not what is the best possible characterization of cognitive function, but really what is the minimum necessary cognitive data you need to make the decisions that have to be made. Now, in the clinic, that could be decisions on who to refer to for studies to the research teams that we oversee, or who and how we want to profile for participation in studies on Alzheimer's disease. But there's a second perspective also. I think that those of you here that are in the business of developing these tools will appreciate, which is the clinicians are also the market and the end user for some of these new tools. So I want to try and offer these two perspectives that bookend, I think, a lot of the richness that Kate, Shefali, and Mike have touched on. Usually for research, we think about maximum possible or highest quality of data. But I'm going to talk not about research studies, but clinical initiatives where we really think about what is the minimum necessary. So Mike alluded to the ADAPT study on which he and I are co-PIs. And this is a study that is essentially looking at how wearable sensors can guide psychopharmacology. But we needed a screener for this that would give us that initial determination of what the severity of someone's cognitive impairment or dementia is. So the population here is people with dementia and coexisting behavior symptoms. And we elected to go with the Montreal Cognitive Assessment because we needed to strike balance between a scale that was relatively easy to use. And we didn't need a deep characterization of cognitive function. The diagnostic, the underlying pathology was not as relevant. But we contrast that with something like the guide model that some of you may be familiar with. Now, this is a CMS initiative, and it's basically a care model that is going to assess how giving people wraparound care that includes caregiver support and respite services impact cost of care. So it's a very different goal. And for this, even though it's a study for dementia, what they're really basing outcomes on is the FAST, which is it's a functional scale that's not as invested in cognitive performance per se, but in this very clinically embedded study, they're really looking at how someone functions in real time. So sometimes you need the cognitive characterization, sometimes the functional, just an estimation of functioning will do. But the next three are examples of scales that at various points I've been involved in picking a screener to standardize and implement across an entire clinical service. So in the McLean Geropsych outpatient service, which I lead at the moment, the typical person we use these for is someone with self-reported cognitive decline. We used to use the MMSE, and it was largely that executive functioning component that the MMSE does not do as good a job of, that the MOCA includes, that led us to switch from the MMSE to the MOCA. But there have been other clinical settings that have been more memory-specific clinics. In a previous role at UC San Diego, where we ran a memory clinic where people had a range of cognitive symptoms. When we had to choose, we went with the Mattis Dementia Rating Scale. Now, this is a little bit more involved, and it gives a more detailed breakdown of cognitive domains. It has some functional elements included. It takes longer. So whereas the MOCA or the MMSE can be done in 10 to 12 minutes, in a clinic that was a memory focused clinic where we wanted a little bit more cognitive characterization, we went with the dementia rating scale. The downside there, of course, was that this was a clinic whose purpose was to actually determine what underlying pathology might be, whether it's Alzheimer's or Parkinson's or vascular. And using a scale like Mattis as a screener, I think, let us estimate functioning and severity. But in order to establish pathology, a screener is not enough. So I think the lesson there is, what are you looking to do with the cognitive characterization that the screener gives you? In the VA clinic that was also part of my San Diego role, this had a much higher volume. So while these were complex older adults, we sometimes had to screen 40 or 50 in the clinic a day. And with a volume that high, even the MOCA was more than we needed. So the VA uses the St. Louis University screener. It has the unfortunate acronym of SLUMS, but if someone were looking for information that's diagnostic or gave clues as to day-to-day functioning, then the SLUMS is not the ideal choice. But when you need to make it through a large number of screens in a small amount of time, and you have to kind of compromise between efficiency and quality, it ends up being a really good choice. So these examples are intended to sort of illustrate that what screener one chooses to use it's worth spending some time thinking about what the role of the screening information is, and recognizing that minimum necessary is sometimes an effective way of picking what screener to use, especially because these are always a small part of a much larger battery of tests or scales. And I think we've learned that the more data you expect people to report, the higher the chance of missingness or even just attrition in participation. So I think the efficiency component matters. Can we go to the next slide? And these are just lessons from the trenches, if you will. Really, if this is a study where characterizing cognition is important, then including executive functioning becomes relevant as well. This is why the MMSE has, I think, fallen out of favor for a lot of studies, especially studies in the dementia realm. I think there are some general geriatric studies with more heterogeneous populations where it still finds use. But executive functioning, I think, really impacts the ability to translate study findings back into the real world. So if you were to think a few steps downstream, then I think those data matter. And we're really realizing that beyond just pure cognitive ability, incorporating functional ability matters. Now, we've heard this from the presentations earlier. So whether it be the inclusion of something like FAST or other scales that get at functioning, I think that's something to consider. It adds to the practical relevance of the data. Speed has value. Again, practically availability in several languages is a strength, and MoCA really stands out on this, that it's in over 25 languages. And that screens that take performance on tasks into account are highly desired, but these are hard to implement, which is to say extracting information on cognition from how someone does on everyday tasks. Shefali will talk about this. And then finally, cost. Some of these, including the MMSC, are now protected by copyright, and even if it's $1 a pop, I think there is great value to using screeners that don't add costs to what are already overloaded study budgets. I'll stop there.
No, thank you so much. Shefali, I'll hand this over to you now.
So I am going to be presenting on using digital neuropsychology, speech AI, and biometric analytics to screen everyday cognitive functioning. So digital neuropsychology or digital cognitive screening really fills gaps in traditional testing by leveraging digital technologies. And this is towards the goal of improving our ability to characterize cognitive and psychological functioning in a way that's more ecologically valid. Right now, as a neuropsychologist, we're getting a single time point of assessment. As Kate mentioned, we're seeing patients once. And there are tools that we have that we can leverage to look at multiple time points of assessment. So I'm, to use Ibsen's phrase, in the trenches, if you will, trying to validate a lot of these tools. So what are these digital tools? So there are cognitive ecological momentary assessments and speech ecological momentary assessments. There's also contextual factors like environmental factors or psychological factors, as well as additional tools like face recognition, computer mouse clicks, pressure pads. So I really like our traditional neuropsych measures. And a lot of that in my work validates these digital tools on more clinical populations. And so what I try to do is figure out, are there cognitive screening tools that are proxies of cognitive function that can be used in lieu of or in addition to our tried and true measures? So briefly, ecological momentary assessment, you're capturing multiple time points of assessment within person. So you get within person data, which is essentially longitudinal, but you also get between person data. This is just an example of some of our digital cognitive tools that we use. We're using primarily Test My Brain, which was created by Laura Germain at McLean. And these are just some of the images that are representative of the tests. We look at domains that like we would in our traditional measures, like working memory, attention, processing speed, verbal and visual memory, executive functioning, and perceptual reasoning. And these tests are given in ultra brief bursts that can last 1 to 2 minutes, and they can be given at multiple time points. And so we find in clinical and community samples, this method has been quite reliable and valid. They're not sensitive and specific to unique diseases like diseases like Alzheimer's, right? But in general, we find that the validity and reliability are actually pretty good. When we're looking at glucog, for example, is a type 1 diabetes group, and moodcog is a sample with mood-related disorders. So speech EMA. So speech has been demonstrated as this sort of proxy of cognition. Everyone's very excited about speech, including me, but we're not entirely sure how it works and how it relates to specific diseases. And so I'm working right now with IBM Digital Health to try to figure out what sort of digital biomarkers can we use in speech that might predict or characterize and stratify diseases, particularly neurodegenerative ones. So this is just an example of what this looks like for one of our participants. They can be closed responses like this, like the quick brown fox jumps over the lazy dog, but we also do variations of the cookie theft task, for example, using DALL-E, which is an AI visual generator. Or, we use things like semantic fluency paradigms where you can look at, things like, name all the boys' names you can think of. And so those are different across each EMA. And, one thing I'd like to do is kind of go through 4 main projects that we're working on just very briefly and talk about what the tools are that we're actually implementing. So with the pandemic, neuropsychologists were sort of bereft of a way of giving cognitive assessments in a standardized way for quite some time. And so from that, we developed the Test My Brain Digital Neuropsychology Toolkit, which is essentially an assessment screening tool that clinicians can use, where you can have the clinician click whichever test they like, and then you get this normative data based on gender, age, and years of education, which again is similar to our traditional measures. Another project is implementing digital neuropsychology in our own clinic. So there's a term that Laura, Jermine, and I developed called hybrid neuropsychology, where we're trying to validate digital cognitive speech measures against traditional neuropsych measures, because hey, if we can do something a bit shorter that's cheaper and is more accessible and rapidly scalable, that can be very meaningful. And we're trying to develop a better way of understanding how cognition, mood, and patient-specific data, for example, those we find in electronic medical records, might relate to diagnoses and patient outcomes. And so the goals are sort of trifold, which is cross-validating these traditional neuropsych measures, which are so great with sensitivity and specificity, specifically for dementia-related disorders, but then also look sort of for patterns captured through responses that relate to specific cognitive impairments and performance validity. So determining whether our patients are engaged is a huge part of what we do in neuropsychology. And so using digital tools to kind of capture that nuance can be very beneficial for us. Now, cognitive screening can also be used against sort of blood-based biomarkers. And so in one of our rare disease studies, we're using cognitive speech EMA, mood questionnaires, and we're also looking at blood phenylalanine levels because this particular disease is phenylketonuria. And we're doing 6 measurements over 1 month and varying them according to time of day and day of week. And we're finding that, speech acquisition can serve as this proxy for cognitive functioning and really correlates with some blood-based biomarkers. So when you have something that has, really chronic disease burden, where people are measuring their blood values every day, being able to get a speech capture that's quite close to an actual blood value is also meaningful. So we collect patients' verbal responses like semantic fluency. And what we found in particular was that response times between words and frequency of words was directly related to blood levels of tyrosine and phenylalanine. And so this, neuropsychology and we have our really great tools, but we're not sort of in this precision medicine model where we can make them totally individualized. And so this is hopefully a step in that direction. And then finally, and I'll just talk about one of these projects, what we're doing right now in, and this is actually funded through the A2 Collective, through the Johns Hopkins AITC. We're looking at patients who are in assisted living facilities. For those of you who are familiar with Bridges, is the one we're working with. And we are doing full neuropsychological batteries, so standard neuropsych batteries. And then we're using actigraphy monitoring to look at HRV, so heart rate variability and steps. And then we're looking at we're using cognitive and speech EMA and the goal here is to see in our groups of no cognitive impairment, mild neurocognitive disorder, major neurocognitive disorder, if there are certain digital phenotypes, if we're looking at all these characteristics that might help characterize and stratify the degrees of impairment. And so that's something that we're really working on and really trying to relate it to our traditional measures. Because, perfect doesn't necessarily have to be the enemy of better if we can come up with ways of triaging things so that way we can get people to the right level of evaluation that they need earlier. So what are some of my lessons? Establishing tools as ecologically valid is a uniquely complex challenge, as all of the presenters have said before me. Sometimes you will need large patient populations that are heterogeneous in gender, race, ethnicity, and diagnoses. Rigorous psychometric validation will be needed to demonstrate adequate sensitivity and specificity. One of the largest barriers is, as Kate mentioned, the maturity of a lot of these digital tools. So the barrier to entry is, how do we adopt these tools? So we'd have to demonstrate that these tools are somehow better or more sensitive than our traditional measures. And then finally, there are a lot of available digital tools. So a challenge will be to determine which ones are most relevant to disease. And the caveat will be that not all tools will be have the same utility for the same disease types. So with that, I think we're turning it over to questions.
Yeah, thank you so much, Shefali. And I've got a variety of questions in the chat right now, and we'll try to get through as many of them as we can. Clearly a really insightful set of speakers. And so the first one that I was gonna ask was about the NIH mobile toolbox. And Kate, you mentioned that you could expand on the use of that a bit.
Yeah, I absolutely. I think the mobile toolbox is a great option that has been recently developed, and we actually use the mobile toolbox in the Harvard Aging Brain Study. I think one of the again, and Shefali's kind of spoke to this, is like there are different use cases for different types of technologies, and one of the barriers in screening for particularly for mild cognitive impairment or dementia is the technology barrier, and so and also like who has a smartphone and is able to use it and independently be able to fill out that type of do that type of questionnaire or type of screening on their phone. So I think there's a great place for things like the mobile toolbox in the context of research studies where people are already enrolled. I think there are these recruitment barriers in initially having someone start out with the digital technology versus bringing them in initially, with a warm handoff or with telephone contact versus trying to just reach out digitally and do the screening completely remotely. So I think that's the larger point of that there are a lot of digital tools that are out there, and they're at various stages of development and validation. There's various levels of access for paid versus not for profit. And so again, that sort of reflects the fact that there isn't sort of an individual gold standard, and that there's different sort of use cases where some of these tools may be appropriate and at different stages of the research project.
No, thank you. That's great. And I have a couple other questions, Deepak, and then I'll make sure that I get to yours. So a couple of the questions in the chat mentioned longitudinal measurements over time. And Kate, you mentioned maybe not using the same instrument over time, but so the two questions relate to, one is how could you think about measuring over time to assess whether there's been an improvement based on some kind of intervention you've done? And then the sort of converse of that, of how do you detect decline over time if you're using different instruments or the same instrument? So if any of you can speak to the longitudinal question, that would be helpful.
Yeah, I mean, that's a huge, very tricky question. Typically in Alzheimer's disease and trials, change or response to treatment has been assessed using a combination of cognitive performance as well as functional change. And these studies have really focused on looking at functional decline over time. But as we've moved earlier in the disease to the preclinical stages or even MCI stages, there's been more of a focus on cognition by itself and not looking at function necessarily, but looking at cognitive change. And there are issues around that in terms of, when you repeat cognitive tests, there's practice effects such that you might see that people are actually getting better, but people who don't get sufficiently better might actually be the ones who are at greater risk of decline. There's a lot of different standard measures that have been used and that are used as cognitive outcomes for studies. And then there's also some newer approaches like things like EMA, which leverages the ability to capture multiple time points to get more valid information and to assess people more frequently. And hopefully, if you assess people more frequently, you can also sort of mitigate that practice effect by having it be more routine as well. So I'm not really answering it very well, but it's a big question. And it's really sort of dependent on the population and the type of intervention. So there's a lot of different decision points, around what types of outcomes to use to assess things longitudinally.
No, thank you. And I'll open it if there's any of the other folks on the panel that have had any experience doing assessments over time.
I can talk a little bit about what we're doing now. So I've been working pretty closely over probably the last year with Marty Slawinski at Penn State, who has developed a set of tools called the M2C2 tools. They're NIH supported, and we've been fortunate. We're like the first group to stand up our own version of their tools on our own hardware. And so we're rolling out studies now that are looking at using that. And some of the nice things about those tools, I think, is Kate was mentioning that like how people change over time can be a really nice measure, or getting an idea of this sort of cognitive stability that people have. Marty's group has really started to focus on that. I think largely a lot of data has come out of the Einstein Aging Project with that. And so there are positives and certainly challenges to that. Actually deploying the tools and having technology base is a requirement, which can be a challenge in and of itself. So how do you administer the tools? How do you trigger the tools? Are they coming the same time every day? We've been looking at doing like event-based triggering. And so how do we import an event that, is subjectively reported and then trigger a EMA assessment to understand like, okay, what is the sort of cognitive status in the moment? But there's different puzzles that can be done. We're looking at roughly things that happen in a minute, and sending out a couple of these at a time. And so we're looking at the way that we're applying these is they have a 14-day run-in where people get these assessments every day, and that sort of you can characterize somebody's status based on the learning effect, but also gets you sort of beyond the learning effect. And then we deploy the assessments a few times a week after that. And so for this particular study, we're going to be going for about 6 months with that. So we'll have lots of assessments from those individuals.
Oh, thank you. I was also going to note that we're going to capture the questions in the chat to offline answer and then distribute. And so feel free to keep adding those. We have a lot more questions than we can get get to in the next couple of minutes. There was one question, Ipsit, related to it seems like slums has a lot of benefits over others. Was there any major reasons to shy away from that as an instrument?
No major reason. I think the big thing about the slums is it just hasn't been studied as extensively and in as many populations as some of the others. So I think its psychometric properties are not quite as well characterized in more diverse populations and in the other languages. I think that really is the biggest drawback, that the other tools are backed by a much bigger set of psychometric and normative data. But it takes half the time as a MoCA sometimes, so it's got a lot of advantages in that sense.
Perfect. And I'll end with one for Shefali. So anything that you can talk about related to use of LLM tools like ChatGPT, or anything related to partnership with IBM, if you're able to talk about that. Those were the two pieces.
Yeah, that's both great questions and complex answers somewhat. So I'll start with the LLM tools and ChatGPT. So there are some new patent technologies that we've been talking about with IBM where there are sort of interventions that can use ChatGPT. For example, you can give a book chapter to an older adult, and they can read that chapter and summarize it using their voice, and then ChatGPT could summarize that and compare it to what would be the actual summary of that chapter. So that could be some sort of way of testing to see things like reading comprehension, but also getting them to elicit responses. Large language models, I think that there's a big push towards going, using electronic medical records and running LLMs through those and trying to see if there are specific disease characteristics that we might be able to pick up ahead of time using those. And so that's something that we're looking at. And then regarding the, and I know these are very short answers, I'm just being mindful of time. And then with the IBM partnership, I would say that they've been very, very collaborative and open. And there are some things where, they're hesitant to develop something that's entirely new that doesn't fall under one of their own patents. And so keeping things open source has been my move with them, and sort of figuring out how to navigate these larger research studies that we're looking to conduct. But it's been actually quite seamless, and they've been great to work with in terms of a partner.
Perfect. No, thank you so much. And again, so many questions that it makes us think that there's enough space here to have a continued discussion. So please, I'm sure, reach out to any of the panelists with specific questions related to their work, and we will do our best to synthesize responses to the questions that you've asked. But thank you again to Kate, Mike, Ipsit, and Shefali for your time today.